Good afternoon, everyone. The topic that is given to me is the role of EUS in diagnosis and staging, especially in GI malignancy. I know this is a huge and the vast topic. I'm trying to limit in the 10 minutes how much ever I can cover in this. So we know that the EUS has evolved over times from radial to linear to FNA and the therapeutic EUS, with which actually we were able to diagnose, characterize the lesion better and also the stage. And now we are in the era of the therapeutic EUS, which some of the cases in the morning we had seen. For the purpose of the talk, I had divided it into two, that is diagnosis, with which using the EUS various methods how we can diagnose, and also in staging a given malignancy, what all the methods we can use and how much it is practicably applicable in day-to-day life. So EUS in diagnosis can be made with EUS per se. It's some of the characteristic feature of a given lesion. Especially this is useful in given pancreatic cystic lesions and also in some of the submucosal lesions. Then with EUS, FNA and FNB and assisted other technique like Rose Mohs, we can give a better results in the EUS diagnosis. There are other methodologies also like using the elastography, contrast, high frequency catheter probe and 3D EUS. We know that like with use of the EUS, FNA or FNB, we can get a accurate diagnosis of almost 80 to 100% in the diagnosis. This was one of the recent paper in 2024 where it says that like using the EUS FNB is the current gold standard in diagnosing the tumors with sensitivity and specificity and accuracy of lastly accuracy of 83 to 95%. It was one of the good paper which I could come across, where apart from the Rose it has mentioned the other different on-site methods like Mohs, microscopic on-site method, OS, that is visual on-site method, and so, and now there is a role of AI also in diagnosing the given sample. Then comes the EUS elastography. Basically it is a non-invasive technique where we are going to estimate the tissue stiffness. Depending on that we are able to tell whether this tissue is a normal or the malignant or whether it is the fibrous one, with which we can give a sensitivity of around 90 to 98% with a specificity of 67 to 76%. So these were some of the picture. Here how the elastography picture looks. The more it is the green, the more it is the soft, the more it is non-malignant, whereas the more it is the blue, the more it will be a malignant. This is more helpful in some of the clinical utility, that is in taking the biopsy from exactly from which area it has to be taken, and it decreases the number of passes. Presently its clinical utility is in lymph node sampling, especially adrenal and some of the pancreatic lesions, and whenever we suspect a infiltration and hence the staging of the luminal malignancies. Similarly we have other method, that is contrast enhanced EUS. Here we are going to use some of the air filled microbubble contrast material that creates the signaling intensity in blood vessels compared to the surrounding tissue, allowing the selective detection of the vascular lesion. So basically we are going to use SonoView, one of the contrast material here. This is how it looks in a given using the contrast. If it is hypoenhancing, this is one of the characteristics of the ductal adenocarcinoma, whereas the neuroendocrines, as they are very vascular, they are going to give a hyperenhancing picture. So these were some of the indication from the EFSMB guideline where all it can be used. For the take of time I am just skipping. So sometimes actually we can combine the elastography and the contrast. That is how the picture looks. A normal EUS which is looking a hypoechoic structure here, with the elastography we can see which are the areas that has been looking as a blue or more pathological, and using the contrast we can see these are like non-enhancing areas which are of hypoenhancing, suggestive of adenocarcinomas. Now there is other different methods like mini probe, where these are usually high frequency 3D dimensional catheter probe we are going to use. The normal one what we use are having a 7.5 to 10 megahertz, whereas here we are using a 20 megahertz mini probes. These are especially useful in staging the luminal malignancy for wall stratification wall thickness, symmetrical and asymmetrical thickening, and of the lymph nodes also. There was one of the recent paper in 2018 from PGI and that included Dr. Rajesh Gupta sir and all, where what they say is, using the mini probe, if there is a wall thickness of more than 9 mm, that has a high sensitivity, specificity and almost accuracy of 78% to 79% to say that malignancy directly without using the other techniques. This was regarding the diagnosis. Now coming to the staging in GI malignancy. So in staging, for the purpose of the better understanding, we can divide them into luminal and non-luminal. In the luminal, again we have the mucosal and the submucosal. Submucosal I am not going to cover in detail, whereas the mucosal, especially these are useful in esophageal, stomach and the rectal, whereas the non-luminal we can use in all of this, but the better we are studied with the EUS is the pancreatic malignancies. So the idea of luminal malignancies and where the EUS is better for the loco-regional staging is, we know that the 5 layers of the given luminal wall can be better differentiated with the EUS as hyper, hypo areas. Depending on which layer is involved, we can give the T staging. So it is better in giving the T staging, and most of these luminal malignancies treatment depends on their T stage. This was example of the esophageal malignancy. It applies to most of the rectal and even the stomach malignancies also. The summary is, the T2 involves actually the muscularis propria, whereas the T3 involves adventia in esophagus, whereas the serosa in rectum. So once the T2 is involved, above which we can consider for surgery are the endoscopic method of treatment, whereas once it is involved the T2, we have to consider the neoadjuvant followed by the surgery. So this is basically the principle. In esophageal malignancy, in the absence of the distant metastasis, EUS is helpful in loco-regional staging, and it has reduced some of the preoperative staging and hence the mortality also, as per this thing. If we consider the treatment for a T1 where we have mucosa involvement, till that we can consider the endoscopic method of treatment. Once the submucosa involved, we can consider the surgery. Once the T2 is involved, where we have to consider the neoadjuvant. So this is the basic principle. So once as these things are these areas of like differentiation is important, so the staging in the luminal malignancies using the EUS as the very high advantages compared to the any other at present given modality like CT or the MRI, where the other things can not give this much of the differentiation. So this was one of the example. We can see the mucosal area that is coming up to the submucosa, and this is the endoscopic picture. So similarly in the lymph node, if they have some of the characteristics like this, they can almost give a 85% chance of the malignancy. This was one of the paper which says that like how much accurately we can give the sensitivity and specificity in EUS. So here what we can see is above the T4 we have more sensitivity and specificity compared to the T1 and T2. For even in the initial stages, that is initial carcinoma in stage, stage of carcinoma in situ, the EMR is more beneficial in staging. But this has some of the limitation also, especially in the earlier stages when already someone has received the neoadjuvant, when you have a stricture but you can't cross through the stricture. But here the bottom line is, it means that once you are unable to cross the stricture, it means that it is an advanced disease. It indicates that it has already involved your above the muscularis propria layer. So similar the other principle applies in the rectum also, but some of the things that does change here is, so till T2 we can do a excision, above we need a pre-op chemotherapy followed by the resection. These were some of the examples. So here I am comparing the EUS and the MRI. For T staging, EUS and MRI are at a given point of the time are almost equal. So presently with for the rectal malignancies, the MRI can be still better used or almost equivalently used than that of the, as that of the EUS also. But in lymph node, if we consider, the EUS may not be a better one as that of the esophagus. The limitations here in the rectal malignancies also hold good as that of the esophagus. I have only few slides. Gastric malignancy, the same principle applies. Early gastric cancers can be treated by the endoscopic method, which include the mucosa and the submucosa, whereas the advanced cancers include the muscularis propria, which needs a neoadjuvant therapy. These things can be better differentiated with the by involving the which layer is involved using the EUS. Again, in the locally advanced malignancies, like where the omental deposits there and ascites there, EUS may not be good, where we have to use the laparoscopy. And again, the nodal staging, EUS may not be good because the number of the lymph node what we are staging in the TNM may not be visible with the EUS, as N1, N2, N3 covers the vast area, as we can see here. So some of the studies, as per the for the T stage, EUS sensitivity is 87%, for the N stage it is 60%, and with the FNB we can say 63 to 97%. The exact role of the pancreatic malignancy comes in EUS and comes in the staging. So pancreatic malignancy using the EUS especially useful when the lesion is less than 2 centimeter in the setting of a chronic pancreatitis, where there is always a confusion of the inflammatory mass versus the malignancy, and in these kind of the lesion using the FNB or using the different techniques like contrast enhancement or the elastography, the lesions can be better delineated and given the diagnosis. And here the staging. So presently, the earlier actually the whatever the CT we were using were less compared to the US, but presently we are using the something called as multi-detector this one CT. So this has almost better sensitivity or equivalent sensitivity as that of the US. So MDHCTs are the present modality for a staging, I can say, which are equivalent with that of the US. This is again the similar slide. So for a arterial and the venous invasion, US again has a better way of diagnosis. Venous is better than that of the arterial. So in my topic, due to the lack of the time, I have now touched some of the areas of the pancreatic cystic lesions and subepithelial lesions and lung malignancy and the staging. So I would like to conclude my talk with saying that the wings of the US has evolved over the years from not only in diagnosis and staging and in therapeutics also, both curative and palliative, which we had seen in our morning cases. Thank you.